Hello viewers, this is Dr. Rajiv. Welcome to your education channel YouTube Surgery and Orthopedic Education. Please consider subscribing to it as well as share it to your near and dears to help them in their preparation of MBBS course as well as other postgraduate and job entrance examinations. Also, please don't forget to press the bell icon below so that you never miss an update from us. In the last talk, we discussed a common breast condition, breast infections and inflammations. Today, we shall talk about another common breast condition, aberrations of normal breast development and involution. Terminology in benign breast disease is confusing because it is not based on sound concepts of pathogenesis. The ANDI classification is based on pathogenesis. It represents a spectrum of breast conditions that ranges from normal to disorder to disease. This classification defines an individual patient problem in terms of pathogenesis, histology, and clinical implications. ND refers to a variety of benign breast disorders that arise due to disturbances in the normal development, hormonal response, and involution or shrinkage of the breast tissue. The concept of ND was described by the Cardiff-based clinic of United Kingdom. ND includes benign breast diseases that consist of four essential features. These are cyst formation, fibrosis, hyperplasia of epithelium lining the ducts with or without atypia, and papillomatosis. Cyst formation is the most common and typical feature of benign breast disease. Most common symptoms in ND are lumpiness or nodularity and breast pain or mastalgia. Lumpiness is diffuse. It is never focal. Mastalgia can be divided into cyclical and non-cyclical. Cyclical mastalgia is often related with ND, but non-cyclical mastalgia is usually not associated with ND, but may be of musculoskeletal origin from the chest wall or may be associated with inflammation caused by duct ectasia or periductal mastitis. It is noteworthy that persistent localized pain or discomfort may be a symptom of cancer also. There may be an increase in both lumpiness and often tenderness before menstruation. Non-cyclical mastalgia is more common in perimenopausal women. Breast pain in postmenopausal women who are not taking hormone replacement therapy usually originates from the chest wall, back, or neck. Lumpiness or nodularity in the breast is a very common symptom. Nodules are often located in the upper outer quadrant and axillary tail region of the breast and may or may not be associated with pain and tenderness. Remember that this region of the breast is also the most common site of breast cancer because this quadrant has the largest volume of breast tissue. Lumps usually become larger and more tender premenstrually. Lumps are often cystic in nature. They can be single or multiple and may grow suddenly or regress. One must notice during examination that whether the nodularity is focal or diffuse. A focal or discrete nodule must be taken seriously and should be examined very carefully to exclude malignancy through fine needle aspiration cytology or FNAC. Diffuse nodularity is often bilateral and is found mainly in the upper and outer quadrant. If the patient is seen first in premenstrual period, she should be examined again in the first half of a cycle. Simple breast cysts present as tender fluid-filled collections. These are seen most commonly in the late reproductive life, usually between 30 and 40 years of life, because of the involution or shrinkage of stroma and epithelium. They are usually multiple, maybe bilateral. typically present suddenly and cause great alarm. They can be confused with breast cancer. Diagnosis can be confirmed by FNAC and ultrasound. Aspiration is diagnostic. It is a simple cyst. If the aspirate is not blood-stained, there is no residual lump after aspiration, it does not refill, and the cytological examination of the aspirated fluid does not show malignant cells. The differential diagnosis of breast swellings simulating cysts can be chronic abscesses, hematoma, galactocele, cystic hyperplasia of fibroadenosis, hydatid cyst, and colloid degeneration of carcinoma. A solitary cyst or a collection of a few cysts can be treated by aspiration. If the cyst resolves completely and its fluid is not blood-stained, no further treatment is required. But unfortunately, 30% may recur and require re-aspiration. After aspiration, if there is a residual lump, if the fluid is blood-stained, or if the cyst reforms repeatedly, a core biopsy or excision biopsy and histological examination is advisable. A galactocele or lacteal cyst or milk cyst typically occurs in lactating women. These are retention cysts containing milk or a milky substance and form due to the obstruction of a lactiferous duct. They present as a solitary, painless subareolar cyst and always develop during or shortly after lactation. Uncommonly, a galactocele can become infected and form an abscess. In long-standing cases, the cyst wall may calcify. The cyst contents can be aspirated using a needle, or in chronic cases, surgical excision may be necessary. Fibroadenoma is a non-proliferative benign breast disease. It commonly occurs in young women, typically between the ages of 15 and 25 years, but occasionally they occur in older women too. It presents as a palpable, mobile, well-defined breast mass, or they may be incidentally detected as a mass on mammography. There is a well-defined capsule around the mass. Most fibroadenomas grow up to 2 to 3 cm in diameter and their size may fluctuate during the menstrual cycle. Fibroadenomas usually present as a firm, painless and freely mobile breast lump. On examination, the lump is not tender and there is no rise in local temperature. The mass is not fixed to the skin or any deeper structures. It is highly mobile and therefore it is also called a breast mouse. There is no enlargement of the axillary lymph nodes. Ultrasound examination of the mass can differentiate it from a cyst. A core needle biopsy should be performed if the patient is over 25 years of age or the ultrasound shows any atypical features. Once diagnosed as a fibroadenoma, it does not require excision unless associated with suspicious cytology or its size is more than 3 cm or the patient desires a surgical removal due to anxiety. A fibroadenoma that grows over 5 cm in diameter and is rapidly growing is known as giant fibroadenoma. It can be enucleated through a submammary incision. These are more common in the Afro-Caribbean population. There is mildly increased risk of breast cancer in fibroadenoma. Phyllodes tumor is a rare benign breast tumor. It was previously known as serocystic disease of Brody and cystosarcoma phyllodes, but it is not cystic and only very rarely becomes sarcomatous. The tumor may increase in size over time and may present as a large mass, sometimes up to 20 cm in diameter. It is usually seen in women over the age of 40 years. Phyllodes tumor presents as a large and mobile tumor having an uneven pocillated surface. Ulceration of the overlying skin may occur because of pressure necrosis. Histologically, Phyllodes tumor forms from the stromal tissue of the breast, not from the ducts or glands. It has low malignant potential like fibroadenoma. Benign tumors are treated by enucleation in young women or wide local excision if large. Massive recurrent and malignant tumors need mastectomy.